ECHO session on HIV and aging. And our session today will be focusing on women's health, particularly in the context of people growing older with HIV. So for those of you who are new who have missed our previous ECHO sessions or any other sessions you would have wanted to attend, you can actually access the recording, the slides, and other resources that have been discussed in the iEcho platform via which you joined the meeting. So thank you. And I'll hand over to Farah first for some announcements before we head into our didactic session. So Farah, over to you.
All right, thank you, Puli. Hello, everyone. So I'll just do a brief talking about like what's the ECHO project is about today, and like the some housekeeping rules. So today we'll be talking about women's health, and to be reminded to change your name, country, and also area of expertise, as you can see how some of us are doing right now. We also encourage everyone to turn on your video and also put your questions in the chat box. We'll be answering your questions during the Q&A or discussion session. And please use the mute button if you are not speaking. And as Prudy said, we will be recording the session and upload the session on YouTube, as well as we'll be sharing the learning materials later on the iEcho platform. So as if you are not new here, like as you know that we have also now enabled the translated captions. So if your first language is not English, you can turn on the translation and be able to see the translated in your preference language. And as for CPD points for the Malaysian clinicians, you would have to fill up the CPD form that I will be sharing in the chat box later to claim for your CPD points. As for the clinicians from Japan and Australia, is all right. It will be submitting your name to the JSAR and also ASHM after the session. And as Puli said, this will be the agenda for today. We'll start with the didactic lead and also the case presentation. And just to share the sessions that are coming up next, which is developing a clinic with integrated care and also advanced care planning by Professor Jaime Vera and also Ms. Cheng Hong. And also for the feedback session, feedback form, I will be sharing this later in the chat box, as well as at the end of the session. And just to remind you all, on the iEcho platform, there is actually a discussion section that is always open. So if you guys have any questions or reflections anytime, everyone can join in the discussion tab and also have a conversation going or like discussion going in any topic that we have discussed previously. I think that's all for the housekeeping rules. Going back to Puli.
Thanks, Farah. Okay, so we're heading into the next part of our session. I'd like to introduce Professor Dr. Yvonne Gilleece, who will be speaking today about women's health in HIV. So Professor Yvonne studied medicine at University College Dublin, graduating with honours in 1993. She continued her training as a junior doctor in Dublin and London, where she developed an interest in HIV medicine. She completed her Specialist Registrar training in Chelsea and Westminster Hospital and was appointed consultant in HIV medicine in Brighton in 2005, where she continues to work as Honorary Clinical Professor and Consultant in HIV Medicine and Sexual Health there. She served as the Honorary Secretary of the British HIV Association from 2018 to 2022 and was elected Chair of BHIVA in 2023, the first non-London chair. She's a national and international leader on HIV, publishing regularly in peer-reviewed journals. She specializes in HIV in women and is immediate past chair of the BHIVA Pregnancy Guidelines, WAVE, a subcommittee of the European AIDS Clinical Society, and SWIFT, promoting research in women living with HIV. She also specializes in HIV and bone and HIV and liver dysfunction. So with that, I'll hand the session over to Professor Yvonne to talk to us today about women in HIV.
Great, thanks very much for that introduction. That's really lovely, thank you. So I'm going to share my screen and please let me know is that all okay?
Yep, that's looking good.
That's great. And has it moved to the next slide?
Not yet. Now
Yeah.
it has. Yeah.
And they're my declarations of interest. So just thinking globally about HIV in women, the majority of the world's population living with HIV are women, and where those women are obviously varies per continent. So we can see where I'm based in Europe, in the UK, about 30% of people living with HIV are women, whereas in Asia and the Pacific, India has a much larger proportion of men rather than women. Africa, about 66% of the population living with HIV. In South Africa in particular are women. You can see that varies per country. So really the services and the care that we need to think about will vary according to our geographical location. However, there are some basic principles that we do need to all think about in the context of HIV and ageing and women. So if we think about HIV treatment and comorbidities, this is old data, but it still really persists in that we know that in the UK, where we've had good treatment for many, many years for HIV, this is data from 2015, but it looked at AIDS-defining illnesses causing death in people living with HIV. But what we could see is that women were far more likely than men to be included in this category. And we know that this still is something we see. We know where women are on treatment during pregnancy, they're very good at taking treatment in pregnancy, but can often stop after pregnancy. And therefore, this is a group we really need to keep engaged in care and in treatment, because women do have additional risks than men. If we look at whether or not treatment works equally in men and women, you'll see that where we are looking for time to virological suppression, so viral load less than 50 copies per mil, that actually if women are able to take their treatment as well as men, that they will get the same response to treatment. So that's a positive. But what we do see is actually where there is a risk of disengaging from care or not being able to take antiretroviral therapy, that actually this is more likely to occur in women rather than men. And this pattern has been shown not only in the UK, but also in other countries as well. We also know that there can be differing side effects in men and women. And so probably the most current issue at the moment is antiretroviral therapy and weight gain. So we first knew that weight gain was an issue with the NAMSAL and advanced studies, which suggested that particularly older Black African women, after 96 weeks of treatment on TAF, dolutegravir and FTC versus dolutegravir with Truvada or efavirenz with Truvada, that there were higher rates in these groups. Now, there's still debate as to whether or not this is coming off TDF or whether it is due to TAF or INSTIs, and this remains a current issue. And it's not only just about weight gain in NAMSAL and advanced, but particularly advanced showed that not only was it weight gain, but it was associated with development of metabolic syndrome. So it can have additional health consequences. Dolphin 2 is a study in pregnancy where women are starting antiretroviral therapy, usually in the third trimester, again using those same three combinations. Same two combinations, the dolutegravir or efavirenz-based treatment. And what we are seeing is more weight gain in the dolutegravir arm, but it varies with regionality. So different countries will see different rates of weight gain within Africa, remembering Africa is a continent, not a country. But actually that weight gain has been shown to be beneficial in the impact study, in that if you have extremes of weight, so loss or high weight gain in pregnancy, babies have poor outcomes, but actually having a good natural weight gain is associated with normal pregnancy, and that hasn't been found where there is a differential between dolutegravir and efavirenz. That weight gain is not deleterious. The US cohort study called OPERA has also noted, particularly where people have had their third anchor drug remaining stable, where they have changed from tenofovir to TAF, a sudden shift upwards in weight in the first 6 months, which then levels out. So again, this is where the thought is, what is causing it? Are antivirals causing weight gain, or are antivirals maintaining weight suppression? So because of the potential development of metabolic syndrome, the risks associated with obesity and the overlapping epidemics of obesity and HIV, it is important to think about weight gain, and particularly if women are more affected. So if we look then at numbers of women in cohorts, we know because HIV is now very treatable, we have numbers of women who are living and aging with HIV. And this is a modern cohort, so based in Italy. And what you can see is that we have increasing numbers of men and women aged over 75 and above 65, but a big majority are in the 50 to 64 age group. And this is quite common in parts of Europe. And we are also seeing this as we get rollout of better treatment globally, that this is a pattern we are going to see, even if it hasn't yet emerged in the geographical location, it will be soon. And although aging is great, we want people to age healthily, because this is data, again, from Europe showing that if you are living with HIV versus not living with HIV, once you go above the age of 65, you are significantly more likely to be living with 2 or 3 comorbidities than people without HIV. And those comorbidities in themselves bring their own need for treatment, but also their additional risks. And if we look sorry, that's just circling that there. If we are looking at what those comorbidities are, we'll see that they are the most commonly things like hypertension, COPD, so chronic obstructive pulmonary disease, and then atraumatic fracture or osteoporosis. And they're really the key things that I want to then focus on in the context of women and aging. So this is a systematic review that I led on with now a junior doctor who's now my colleague, Sonia Rafe, and this was published in HIV Medicine on International Women's Day in 2023. And what we wanted to do was look at comorbidities in women living with HIV, particularly in an older age group. I'm showing you the PRISMA flow chart, which is the basis of our research, because we started off with 3,000 articles. But actually, by the time we got down to what we were looking for, which was including gender-based differences between men and women in the context of HIV, we ended up with 38 articles covering cardiovascular disease, renal disease, bone disease, and neurocognitive disease. So really, you can see there is a dearth of research in this context. And then this next slide shows that actually when we looked at things like myocardial disease, myocardial infarction, cardiovascular risk, which are probably the most common things that we've seen in that European study, but also that we think about in the context of menopause, we can see really clearly that actually we only came up with 6 studies that were going to qualify as inclusive to be included in our study. And so what we are understanding is that modifiable cardiovascular risk is very common, but poorly managed in women living with, but also without HIV. It is something that has always been perceived to be a male disease. 53% of cardiovascular events globally are in women, not in men. Therefore, we do really need to change our thinking here. We also note that cardiac CT angio can be different in people living with and without HIV. And this is part of the issue, is that screening can be more difficult in that our framing and risk calculations can underestimate. But CT angiography may not recognize HIV plaques, which tend to be inflammatory and explosive rather than calcified, which is more common in HIV negative people. Therefore, all of our normal screening tools may be less effective. But also then when women are having MIs, we know that they tend to have ECGs that may not be classic acute MI with ST elevation. So this can be more difficult to recognise, but also we know women in general can sometimes present with arm and jaw or back pain rather than chest pain. And this is something we are also seeing in women with HIV. So we need to think about this. And this is data looking at risk of myocardial infarction, stroke, and heart failure in numerous different studies with different populations. And what we are seeing is that the magnitude of HIV-related risk is higher in women compared to men. So again, this is something we need to think about in our women as they age. And I'm sure you're all very familiar with the REPRIEVE study, which is obviously presented at every conference now. So we knew from last year that the study of 7,000 individuals with a low cardiovascular risk, either given a statin, which was a generic statin available at the time, pitavastatin, versus a placebo, we saw that cardiovascular risk was reduced really significantly by 35%, only 17% of which could be explained by lipid changes. Therefore, we think there's an 18% of other, possibly anti-inflammatory effect of statins that can be really beneficial. And this slide, really what I want to draw your attention to is that actually the risk is no different for men and women. So although there are regional differences, higher rates in people with comorbidities such as diabetes, which you would imagine, women and men have the same risk. Therefore, this is part of the reasoning behind BHIVA, so the British HIV Association's rapid statin guidance for all people living with HIV aged over 40 to consider a statin, but certainly over 50. The only caveat would be for women is that you need to think about whether or not they want to conceive, because avoiding a statin during that period would be essential. But otherwise, we would very, very proactively. We would very proactively advocate that we give statins to women. So certainly in my clinic, I am probably more proactive in getting women onto statins than men, because I want to make sure that they are treated properly, because often men will be picked up by primary care services as needing a statin, women less likely in the UK. So other things that we're seeing in women as well as they age, and again related to metabolic dysfunction, this is data from CROI in 2023, looking at changes in presentation of steatosis in men versus women living with HIV. So in this population with an average age of about 52, a quarter of the female, they had some evidence of fatty liver with a raised CAP score on FibroScan. They had a BMI greater than 25 and type 2 diabetes, and their fibrosis score was greater than 8 kPa. So, sorry about this. And so what they found was the incidence of metabolic associated fatty liver disease between men and women was the same. But when you looked at the more serious thing, which is liver fibrosis, you are seeing it's higher in women, particularly if they're aged over 50. So again, this is something that we need to make sure we are thinking about and assessing women for. The cause of the difference, we don't yet know, because this is all still really early and under-researched data. Could it be related to having HRT versus not having HRT? Could it be related to viral co-infection? We're not really sure yet. So these are all issues that we need to think about in this context. So sorry about this. And then bone. We always think of bone in the context of women. Now, this is an old slide, but I want to show you this because I think it's surprising that actually so what we, I'm really sorry. I'm really sorry. Do you mind if I just...
yeah, do you need to take the call?
An urgency. Give me one second. Apologies. No. Apologies for that. Um, household emergencies. So osteopenia, osteoporosis. So for all of us, with or without HIV, as we age, bone mineral density is a problem, and that's men and women. And what we know is if we reduce our bone mineral density, it's asymptomatic, and we do not know what our fracture risk will be, most notably until we have a fracture. But we're all classically aware of older women, broken hips, whether they have HIV or not. So this is data from Michael Yin and his group, and they have done a lot of research in bone and also in women. What they've looked at is higher rates of osteopenia and osteoporosis and low bone mineral density, whether or not you have HIV. And there's very definitely a higher risk of low bone mineral density in all sites, so that's spine, total hip and femoral neck in women living with HIV. It's very much related to menopause, but can occur earlier. So in my cohort, I do bone scans quite early at the age of 45, and I'm seeing rates of osteoporosis already about 23%, and the average age of women with osteoporosis is the menopause age, it's 53. So it's not like they've had menopause or loss of estrogen for many years. They already are menopausal, are osteoporotic at menopause. The other thing to think about is bone fracture risk. So everybody thinks osteoporosis is the highest bone fracture risk. Often it actually occurs in the osteopenic range because women tend to be more active because they're slightly younger than in the osteoporotic range. And that's when they might be at more risk, say, of falling off a bike or having some kind of risk that may cause them to have fracture. Obviously, osteoporosis increases your non-traumatic fracture risk. But it is a really important thing to think about bone mineral density in women who are aging, because we then need to think about how to manage it. Because it's not only HIV, but there are multiple other risk factors. So we have HIV, the virus, antiretrovirals, so avoiding antivirals potentially like tenofovir or protease inhibitors. But then there are all these other issues that we can potentially modify. Female sex and menopause, obviously, we can't. However, we can think about HRT, and I'll talk about that in a moment. Smoking and family history. Family history is the most significant. So hip fracture, family history of a hip fracture is really the big thing. Immobility, modifiable, but then being white, female, and age, we can't modify. But then the chronic other diseases, so things that we're thinking about for comorbidities, including renal disease, malnutrition, low BMI, medications. So some of the other medications that we're seeing to treat the common comorbidities amongst our patients as well. So all of this really needs to be assessed in women. And why are
5 minutes?
5 minutes, thank you. So why are men and women so different? So really, it's all about immune activation and inflammation, because although we have pregnancy and reproductive orders that can potentially change activation and immune system and cause inflammation, the reality is as we are aging, and this is really the biggie, is we reduce our endogenous estrogen, and therefore we have a loss of our ovarian reserve, and those two combined means that all of this systematic inflammation, which was being kept at bay by estrogen, is lost as we hit menopause, and that starts to increase. And that's probably the key reason why all of these risks need to be thought about, these comorbidities, ahead of menopause, but particularly as women become menopausal. And therefore, we need to think about HRT, and this is from the Liverpool website, looking specifically at interactions between HRT and HIV treatment. And what you can see is that the newer treatments are really not a problem with HRT, and there is no contraindication for HRT for women with HIV specifically. So they would have the same contraindications as HIV negative women. So it is something that we would need to think about. We don't yet know for cardiovascular disease how effective this might be in reducing inflammation and cardiovascular risk, but we do know that HRT benefits bone mineral density in the general population of women. Therefore, we can assume it should have the same effect in women with HIV, but we don't have the data yet. So really, when you're thinking about caring for women with HIV as they age, the multidisciplinary team is key. So we need a whole gamut of individuals. And it's nice to see lots of different doctors on this call today, because this is really, really key. But also nursing and pharmacy care are also very, very important. Because all of these things, we need to keep people on treatment, on the right treatment, but then also managing other comorbidities as a team with people who have expertise. So in our clinic here in Brighton, we have a clinic called Sunflower Clinic, which is alternate weeks for women with HIV, because what we want to do is make sure that all of these different issues are addressed, because it takes time to think about contraception, menopause, cervical screening, psychological support, but also the HIV care, including bone cardiovascular risk assessment and intervention. And the average age of women in our clinic is 44, but you can see the age range is really vast. It's 18 to 87, so lots of different issues for each woman. These are some of the nursing assessments that we do. I'll just draw your attention. Probably the main thing is the menopause response score, which is available online. The score of over 17 suggests significant menopausal symptoms. Remember, that can occur before the average age of menopause of 51. It can occur anytime in the perimenopause phase with normal periods, and HRT can still be beneficial. And also we have not only medication, but exercise programs to keep muscles in shape, because muscles very good for bone mineral density. Peer mentorship, again, to help with understanding kind of how women can talk about bone risk. Cardiovasculars can help each other to understand how diet and lifestyle can really impact very positively there. And therefore community support. We have Lunch Positive, which again provides information on healthy eating and provides free lunches and ability for women to talk and meet together. I'm going to move on to research, which is really the key thing. Women need to be included in research. And one of the main reasons they were excluded was because of thalidomide. That was never researched in women. It was rolled out after animal studies only. So it's important to remember women should be included in studies, and pregnancy should not be an exclusion. It's unethical to exclude women. And all of these barriers exist for all of us in the context of clinical trials. We think that women may not be able to be involved for various reasons, and they might choose not to be involved. But sometimes I think healthcare professionals are guilty of making those decisions for women without actually consulting them. There are, again, examples of exclusion and inclusion criteria which are so stark, i.e. get your partner sterilised, that actually women are never going to be involved. So luckily, this is a long time ago, but this is genuinely from a trial that we had in our clinic at one point. So we need to move on from this, because women remain underrepresented in all studies. And it's not just HIV studies. This is the same for cardiovascular health, for endocrine studies, for lots of different studies. And think about all these different things that we need to think about in the context of women and HIV. And we don't really have the data to inform how we want to care for women. Going back to studies and participants and involvement, we keep talking about involving them. So how good are we at doing this? So this is kind of my final bit. So this is a really good systematic review from 2020, looking at the population of people living with HIV globally and who was being invited or being involved in the trials at the time. And these were 24 phase 3 studies in the drugs that we all use today, so dolutegravir, bictegravir, TAF, and doravirine, so the newer drugs. So the global population of HIV when people were being recruited was 42% Black women, 30% Black men, and then smaller numbers of white women, white men, and people of another race. Who was in the studies at the time? The complete opposite. You will see 7% Black women, 17% Black men, 13% white women, 50% white men. We still have to really work at this, because it just seems to be that it is always men who come forward for the studies, but it's up to us to really encourage women to be involved and to help them understand that it's in their interest, so that we can understand gender differences better. Because I've talked to you about the lack of data. We are still at that point where we have lack of data and we need more information. So in summary, the majority of the people living with HIV globally are women. Women may experience different comorbidities as they age. Therefore, we need to think about that and screen. We need more evidence base, however, to ensure women's care can be optimised. And new models of care, I think, are important for women and can be used to provide a holistic approach that women may need. But proper assessment is really essential to ensure that as people age, they age well and don't just get old and frail, but they age as well as possible and stay independent for as long as possible. So research is really the key. Thanks very much for listening, and apologies again for the interruption.
Not at all, Yvonne. Thank you so much for that presentation. I have a lot of questions. It's just such an interesting presentation, and I think a lot of it is it's very, unfortunately, a lot of what you're saying is quite new to me, in terms of, the major differences with men and women. I think what struck me the most was about the cardiovascular disease and how they actually present
Yes.
so differently for myocardial infarction. So there's a lot of food for thought following your presentation. But I'd like to open up the session for the next 10 minutes to the floor for others to ask their questions. So maybe we'll just stop sharing your slides and then.
Sorry.
Oh, no. Thank you. Jenny?
Thanks, Yvonne. That was really fabulous.
Thanks, Jen.
Here in Australia, the proportion of people living with HIV who are women are actually 13%. So it's overwhelmingly a male predominant epidemic here. And we struggle to get women onto clinical trials. I really appreciate the need, and we try really hard to recruit women and to interest women in all sorts of studies, investigator-initiated pharma studies, cure studies, etc. And we are a city that actually does a lot of research. Do you have any advice on how we can increase the proportion of women involved in clinical trials and research?
I mean, I agree, it's really hard, Jenny. So in my clinic in Brighton, we have the same percentage of women in attending our clinic as you have. So, which is why we did a women-only clinic, because actually we surveyed women to find out what they wanted. And actually they found the waiting room they didn't feel was a very nice place for them to be, because they felt it was very male-dominated. Things we hadn't actually thought about, that we thought we were quite an open clinic for everybody. But actually women found it's quite daunting sitting in a room full of men. And so that's why we created that safe space, alternate weeks for them, where it's women only. They see lots of different members of the team. So actually they feel it's quite a safe space. And not every woman needs to come to that clinic more than once. We want them to come at least once to assess everything, because that's often an opportunity for us then to talk to them a bit more about their health, because we have more time, and to get them to think a bit more about research. And we know from the PRIME study in the UK that if women are interested in the study and if things are explained to them properly, they will be recruited. So the PRIME study in the UK is a study of perimenopause and menopause. 850 women participated. So it's not that women don't want to participate. They need to understand the research question, and they need to understand why it might be relevant to them. And then they may want to be more involved. But there is the difficulties that often here they're working 2 jobs, they're caring for children, they're doing lots of other things. So it's making sure there are the incentives there, and that the studies are realistic in their time expectation of candidates for women to be able to be involved. So I think lobbying pharma in the first place for their inclusion exclusion criteria, study visits, and thinking about incentives is really, really key. And involving women in the study design in the first place, that community peer mentorship can help to recruit people, because if women understand, women have been part of the study design, it tends to be that somehow the study becomes more woman friendly. I'm not talking just only women, men should be as well. PPI is really, really important. So I would suggest getting women involved in study design from the off is really, really key. And I don't know what the pharmaceutical rules are in Australia, but even your internal studies, your original piece of research, if you involve people, it tends to make the study more focused on getting the people you want to come into the study successful. That's what we found. But I don't have the magic answer. I wish I did.
Thanks, Jenny. Does anyone else have any more questions? I think while we wait for further questions, I do have a question. I'm quite interested to find out, how do you get women into your clinic? Like, is there a triage system or a checklist to give to the general HIV clinic to refer the women into the Sunflower Clinic? Or is it just that all women are required to go into the clinic once a year, or how does it work?
So it's a variation. So particularly women who are newly diagnosed, they will get a sunflower appointment because we have, we provide psychosocial input. So we have a health advisor and a women's health worker to meet with them first, to talk to them about any psychological issues, to talk about peer mentorship, to talk about the women's group in Brighton and what services are available. And then they see me as the medic to go through things, and then the nurse who goes through, blood, cervical screening, blood pressure, but also will do the framing and risk score and MRS score, etc. So all of those things. So the clinic knows that this is available, and we every so often update them as to what's been happening. We do presentations at our education sessions just to show kind of how we have the time to do things like DEXA scans and then follow up on that a bit more than the general clinic would. Particularly though, if there's a menopause question, the women will often come through. So that will be dictated by women coming through saying, I've got really bad menopause symptoms, and then people will come into our clinic from that, at which point we do everything as well as menopause assessment. So it varies, and we haven't yet gotten through the whole cohort, but we do intend to. And some women then have recurrent issues that they need to come back into clinic for. So we tend to rebook them in. So it's really variable, but it's some women, will have really good care from their primary care, so they don't necessarily need or want to come to us. But I do think the other thing that we have been involved with is a women's health hub, which is a national piece of work in women in general, trying to improve their health. And included in that is cardiovascular assessments being done at kind of standard women's appointments, including contraception, etc. So we tick that box. Therefore, we have become part of the Women's Health Hub as an HIV outpost for it. So aligning yourself with national programs can be another way to get women into your clinic, or to try and highlight the additional needs, because cardiovascular risk is something that the UK want to improve in women in general. And therefore our clinic aligns with that. Therefore, you get a bit more attention and education opportunities for the staff to be able to understand more and therefore educate women more.
Thank you. And the other thing that really struck me when I was there as well was the Sussex Beacon, the group of, was it Positive Living,
Yes.
with the exercise and getting everyone together. Because at the moment, one of our struggles is actually to try to get the women together
Yes.
for a support group, because as you kind of briefly touched on, women are they're looking after their families, they're working multiple jobs. It's very hard to get them to come together. So I was wondering whether you have any kind of advice or experience with how you manage to facilitate this.
So again, it's almost like it's kind of repeated opportunities. So the nursing staff tell them at their bloods, then they come to Sunflower, we talk to them about it. But also it tends to be word of mouth, but women are more stigmatized internally than men about HIV, and therefore they worry about opening up, Whereas when they meet someone from the service, and we know this in general in the UK, we had our conference recently and the peer mentor program was presented. When they meet another a peer mentor, they tend to be more interested in what's on offer than if a medic or a nurse is telling them. So having a peer mentor presence in clinic can make a big difference as to whether or not people will engage with the groups or the peer mentoring or the, the exercise programs that you might have ongoing. So I would really, recommend peer mentorship as a way in. And that has worked well. Our women's group was tiny and is now much bigger and has lots of different days and events. And as you say, the exercise program as well. And then Lunch Positive have gone from just being a Brighton-based, largely predominantly male meeting on a Friday, now has specific menopause women's lunches in different parts of Sussex. So again, they're expanding as well. It's taken time, but you can get there. But peer mentorship is key.
Thank you. Yeah, that is definitely not something to consider because I think even without the peer mentors that we've had in the past, they're mostly men. So actually it'd be really helpful to have a woman's presence, especially to get them engaged early on with other peers.
Yes. Yeah, no, you do have to seek them out. Yeah.
Thank you. Do we have any questions? All right. I think if anyone has any other questions, maybe you can put it in the chat box and maybe Prof. Yvonne, if you don't mind, you can answer them in the chat box. Thank you very much for that talk. I just have so much to think about right now. So thank you very much for that. And now we'll move on to our next session, which is a case presentation on a case of a woman living with HIV, and then we will welcome everyone's input on it. So I'd just like to introduce our case presenter, Dr. Anjana Kukreja. She is a wonderful colleague and friend, and we work together in the University Malaya Medical Center in Malaysia. Her interests are in HIV, particularly with a focus on women, and she has done a lot of research in this area and is paving the way to improve clinical care for women at our center and beyond. So I can't think of a better person to present this month's case. I welcome Dr. Anjana.
Thank you, Puli. Thank you for that very kind introduction. And thank you, Dr. Yvonne, for your presentation earlier, because I hope to someday make it to your clinic because I'm hoping to start something like that in our center, like at least some sort of integrated services. Are my slides visible?
Yes.
Yeah, okay. So I'd like to share a case of a woman from our clinic. So let me introduce you to Madam G. She's a 48-year-old heterosexual female of Chinese ethnicity, and she's not from the key population. So she presented to us actually for her usual ID clinic follow-up, and she complained of hot flushes, difficulty in sleeping, joint pain, dry skin, and a labile mood. So these symptoms started around January this year. And we referred her to the gynecology team who started her on hormone replacement therapy for menopausal symptoms. But what happened was the hormone therapy worked in terms of improving her symptoms, but 2 weeks after being on treatment, she had breakthrough heavy menstrual bleeding for 4 days. And this is on a background of not having her period for over a year. So that menstrual bleeding stopped on its own, but 2 weeks again, it occurred again. So because there were 2 breakthrough bleeds, the tibolone was stopped and endometrial sampling was done to look for endometrial cancer, but thankfully the results came back negative. Once the medication was stopped, her symptoms were still quite difficult to manage. So we actually referred her back to a menopausal specialist who just recently saw her in April and started her on another combination hormonal therapy. So in general, she's independent for her activities of daily living. In fact, she's caring for many people, and I'll share a bit more on that later. She has no problems with her vision and hearing. She still drives around. Her cognition is good. Her sleep health has been recently poor, which she recalls from January. And the main issue she has with sleep is just falling asleep. So once she's asleep, it's all right, but it's difficulty with falling asleep. She doesn't have a very healthy diet. Her meal times are quite erratic with sometimes late dinners at 11 o'clock at night. At what Malaysia is famous for, which is mamak. So just the picture here just shows what mamak food actually is. It's just essentially fried carbohydrates, which she tends to eat quite late at night as well. And lately, because she's been having a lot of hot flushes, she's been drinking like cold, sugary drinks to cool herself down. And that hasn't really been helping with her diet either. She also has depression, which was diagnosed many years ago, and she's stable on treatment for that. But just recently, she feels her mood, she's having a bit more mood swings and more labile. She's divorced, she's currently single and not sexually active, and she doesn't have a history of substance use. She lives in a condominium which she owns and is still paying her monthly house loan. So her social support, or rather the lack of it, is something that I think is important to highlight. She lives alone. She has a daughter who's 26 years old living with her partner, but her daughter doesn't know about her HIV status and she's not quite ready to share it with her daughter just yet. She, Madam G, is the primary caregiver to her dad, who also lives alone but close enough to her. And he has multiple comorbidities. So she's responsible for taking him for all his follow-ups at different clinics and different hospitals. And that takes quite a sizable amount of time away from work for her. Her ex-husband, who actually has another family now, but when it comes to his HIV care, she still takes him to clinic, make sure he gets his meds and everything in terms of his HIV care. She has 5 other siblings who are healthy, but they don't live as close to her dad as she does, so she tends to take the weight of the responsibility when it comes to her father. She works as a perfume salesperson, and she's got quite a fairly understanding boss who lets her work shifts to work around all of these hospital visits. Aside from her HIV, she's acquired quite a number of comorbidities over the years as she's aged. She's got type 2 diabetes, dyslipidemia, osteopenia, major depressive disorder, and CIN1 with high-risk HPV. So a lot of the things that Dr. Yvonne shared as well earlier that women go through. So I just share a bit about her HIV. She's been diagnosed over 2 decades now, since 2001. And at the point of diagnosis, she had advanced disease in presentation in that her nadir CD4 was only 16. But she had thankfully no opportunistic infections at diagnosis, and she does not have hepatitis B or C co-infections. She's quite experienced in terms of her antiretroviral therapy, and you can see her whole journey here over the last 20 years. The initial part, she struggled a bit with achieving virological suppression, but since the switch to Combivir and Kaletra in 2007, she's actually been virally suppressed, and the main reason for medication changes have actually been side effects of the antiretroviral therapy. In the last 10 years, she's been on Kivexan, dolutegravir, and she's quite happy with this regimen at the moment because she feels she's doing fine on it. So thankfully, despite starting at a very low nadir CD4, she has achieved quite good immunological recovery, and she has been virally suppressed for years now. With regards to her diabetes, she was diagnosed in 2015 on routine blood screen when we noticed that her HbA1c was 7.5 right here on the top. So she was started on metformin and glycoside, and just a few months after that, the HbA1c had drastically dropped from 7.5 to 5.2%. And here there were episodes of hypoglycemia kind of reported. So that's why her glycoside was stopped, and she was continuing on metformin all this while, was doing fairly stable until 2024 when it suddenly jumped to 8.6. At this juncture, there were a lot of changes in her diet and her life. But at the same time, that's when we kind of also realized we overlooked that she was on too high a dose of metformin, considering she's also on dolutegravir because of the drug-drug interactions. So we reduced her metformin to 500 twice a day and started her on empagliflozin. With that, there has been a drop in her HbA1c to 7.7%, as well as a bit of a drop in weight as well, which we attribute to the empagliflozin. But 7.7 is still not ideal. And so after discussion with the endocrinologist, they felt we should retrial glycoside because her BMI is still like 22 within the normal range, and increasing empagliflozin would make her lose further weight, and that wasn't really the target here. They also felt that cost was another reason. If empagliflozin is rather expensive in our center compared to glycoside, which is almost free. So we're going to see her again and see if she's doing okay with this glycoside. She's also got dyslipidemia with a history of statin-induced myositis on the older versions of statin. She's on atorvastatin 20, and she's been doing actually quite okay with that, except the most recent triglycerides were really high at 3.0, but we've just kind of talked to her about her diet about it and haven't adjusted any of her medications yet. She also has osteopenia, which was coupled with vitamin D deficiency initially in 2015. That vitamin D deficiency has been fairly corrected now. But when we calculate her FRAX score, her 10-year probability is about 7.4% for a major osteoporotic fracture. So she doesn't warrant treatment per se, but this is something that we have to keep monitoring as she ages. She's also got a CIN1 with high-risk HPV. So this was done on routine screening, and we initially found out that she had a HPV 39 positive, and she had a colposcopy, which showed a low-grade SIL. Then 1 year later, her HPV DNA was repeated, and it was negative. And then it was repeated again in 2023, and this time it showed 52. A repeat colposcopy was done, which shows CIN. And she's due for a repeat HPV test, which we haven't gotten done yet. In terms of vaccinations, she's fairly up to date. She's got her COVID-19, both primary and boosters. She's due for her influenza at her next visit, and her pneumococcal vaccination is complete, and she's next due for a repeat in 2028. So this is just a summary of all the medications that she's on. So it's a lot of polypharmacy, both her two different pills for her antiretroviral therapy, her statin, 3 different medications for diabetes with a calcium that was added in a long time ago because of the osteopenia, and it's just being continued. And then she's got her medications for her major depressive disorder, as well as the most recently added hormonal therapy. So I really wanted to discuss about the difficulties in managing menopausal symptoms, and exploring the appropriate hormonal and non-hormonal options and how to kind of support symptom relief effectively in HIV care. Also like to discuss about, optimizing her diabetes control in the context of HIV and polypharmacy, and also talk about designing a multidisciplinary women-centered care models for women with HIV and caregiving roles. Thank you.
Thanks, Andrew. I think that painted a picture quite similar to Prof. Yvonne's presentation of the issues that women are facing, especially those with HIV. So maybe I'll open the floor to our hub members if they have any questions for Dr. Anjana, just to clarify anything. And Jenny and Grace, do you have any questions? Jenny?
Thanks, Anjana. I wonder whether you have the opportunity to switch her NRTI background. Abacavir is known to be associated with cardiovascular disease, and she's 48. She's on a statin, although possibly the statin dose could be increased. But is there any opportunity? She's got diabetes, which will raise her cardiovascular risk as well. Is there an ability to switch out that abacavir to something else that might reduce her cardiovascular risk?
Yeah, thank you, Dr. Jenny. Yeah, that's a conversation we've had as well about actually thinking of switching her to a 2-drug regimen, like just lamivudine and dolutegravir. And we thought we would sort out the menopausal symptoms and see her back and then try the 2-drug regimen. But yeah, we were thinking of switching her to a 2-drug regimen because, as you rightly said, she's very high risk for cardiovascular disease.
Yeah, and I think if I'm not mistaken, at one point we were having a shortage of just having lamivudine, so we couldn't really rationalize her backbone, unfortunately. But yeah, that's definitely something that we're aiming for. Yvonne, did you have your hand raised?
Yeah, no, I was just going to say exactly that. I mean, I would drop the abacavir as soon as you can, because that's, if you're just going to drop back to a 2-drug regimen, if you have availability of that, it then, it gives you that scope, doesn't it, to look at HRT, because you're not introducing anything new, so you don't need to wait for anything to settle, because if she's undetectable on 3 drugs, she'll be undetectable on 2 drugs. So yeah, I would do exactly that as well. I guess just thinking as well, kind of more broadly, if you are going to change things, is dolutegravir the best thing for her given her depressive disorder? Because sometimes, certainly that's something that we would consider. And just thinking of BMI, we know that dolutegravir integrases have been thought about in that context as well. But there's so many different ways you could look at her antivirals, what to give her and what to change her to. And sometimes just at least getting rid of one difficult drug, which we know long-term is not something you want to keep her on anyway, would probably be the most immediate thing, but just then thinking longer term what might work for her.
Thanks, Yvonne. And what about, so just in terms of the discussion surrounding the antiretrovirals, what other options would you consider in her case?
So I guess, is it possible to, and Jana, just to go back to her antiretroviral history and just to go back and have a look at that, because that's what we would always do. We do everything on a case-by-case basis, and we do it with an MDT, so we make sure that there's more than one head thinking about what needs to happen. So she's had virological failure on NNRTIs. I guess it'd be good to know what the resistance pattern would be, because we know that some NNRTIs can be a bit different, or you wouldn't want to necessarily come back in, but it may be that something like doravirine could work, because unless, we know that there are different resistance patterns for nevirapine, be the 181 or efavirenz, versus rilpivirine or doravirine. So it'd be just knowing the resistance test to be able to think about that, but it wouldn't be the first thing I would reach for. I think probably 3TC Dolly is the safest first option, because you're not giving her any potential new side effects. But I guess if you were thinking, do you see more weight gain with dolutegravir versus bictegravir? I think that the debate is on about that. I don't think we know yet. And I think if you want to give bictegravir, you have to give it with TAF. So you're not coming off tenofovir, unlike, say, the upper cohort, and onto TAF. But is TAF causing weight gain? We don't know. So, I mean, that could be, Biktarvy, a single tablet, given all of the other things that she's on. But I don't know the availability of that in your, and that's it exactly, isn't it? I mean, that's the thing. It's all very well to say, but I think probably the simplest, I think it'd be really important to go through the different options, but the simplest would be 3TC Dolly based on her HEP status, if she has enough SAB, but knowing that SABs aren't always entirely protective. If somebody is core positive, there is a potential risk of reactivation.
Mm-hmm. Yeah. Unfortunately, our access to antiretrovirals are quite limited, which is, something that we keep arguing with pharmaceutical companies, because then if we can't bring it in, we can't really do very much, personalized medicine for our patients, which is a bit of a shame.
No, absolutely. I completely agree, because I think particularly for menopausal women, I think it's really, really key, more so than for men, because there are so many things that you need to think about. You have to avoid PIs and the old NNRTIs with HRT, because it will completely, metabolize it and reduce any hormone availability. And so it can limit what you can then give somebody. Can I ask what the block is? Is it price from pharmaceutical companies, or is it governments not allowing medications or pharma companies to bring drugs in?
I think because Malaysia is now an upper middle income country, so we're not quite lower middle income enough to qualify for getting aid. Grace is laughing, but we're not high income enough either. So that's why we're in a bit of a limbo.
Okay.
Grace, did you want to ask something?
Well, yes. Well, I just would like to have a question and comment on the co-medication. So, I think in the presentation, it was mentioned that statin-induced myositis was one of the problems that this particular lady had. So, but she was currently on atorvastatin, I think. So I would like to clarify that part of history. And secondly, a comment is the polypharmacy issue that was mentioned. Well, going through the medication list, I don't really think there's much room for reducing the current medications. But if the combination pills are available, which in Hong Kong we do have some options, for example, for diabetes. So I do find that even with the same number of medications, but actually reducing the pill burden would be good and improving adherence for many of our patients here.
Thanks, Grace. Totally agree. Kajal?
Oh, hi. Thank you, Anju, for such a nice, interesting case. I was just going to continue from Dr. Grace, the polypharmacy bit of it. Saw that she's on sertraline and also alprazolam, and I wonder if she has been on it for a long time because she's relatively rather young. And if she's going to be on a sleeping pill for a long time, then that on the long run is going to cause her to have some form of benzodiazepine dependency, and it's not going to be really easy to get her off later on. If this is just at this time when she had perimenopausal symptoms, then it's fair. But otherwise, I wonder whether some other modes of medication on non-pharmacal way can actually help her with because it looks like her trouble is only sleep initiation, not much of maintaining the sleep. And secondly is also sertraline and alprazolam has got a drug-drug interaction. So it tends to keep the alprazolam because of the inhibitor. It increases the alprazolam. So on the long run, she probably may be at a little bit higher risk of getting alprazolam toxicity. I mean, no, we're going to talk about reducing medications. In fact, I thought that she probably should have her vitamin D that I don't think I saw in the, I don't think I saw vitamin D in the prescription. So much for wanting to reduce, but yeah.
She's on calcium at the moment, and I think her vitamin D is within the normal range. Would you supplement vitamin D on top of that?
So we do actually, but it also depends on what her day-to-day activities are, because we do know even in our country, despite being in a very sun-rich country, women do gradually have vitamin D deficiency. And also given her diet that is really unhealthy. So I would actually still give her, I know her vitamin D is normal there, but she's already osteopenic. So she is definitely at risk. And if you want to help her with the bones, you also want to make sure that she remains vitamin D and calcium repleted all through the time.
So just like 1 to 2,000 units?
Yeah, that's what I would
day?
give. Correct. And because there's lots of pills, then we can actually give her the monthly dosing. Though I know now we're moving away from the high doses, but if she has got troubles with, daily lots consumption of medications, then we can switch her to the monthly dosings.
Thank you. Jenny?
Can you get the combined vitamin D and calcium carbonate? We get that over the counter. The supplements, the vitamin supplements. So
We
that
get
would
it too.
be reducing one pill if you're adding the vitamin D, if you can combine the two.
We
Yeah,
get
I
it
think
too. We have Mitocal. It's just that these are all drugs to be purchased out of pocket.
Right. Okay.
yeah, but I mean there's
It's
definitely
cheaper for
something.
our patients to get it over the counter than for us to write a prescription for them. It's
I
very
think
different in different countries.
yeah, I think ours is slightly different, although now I think it depends on the center, and we're changing a lot of our billing, so that might be the case for us soon. Yeah, I think with the sertraline and alprazolam, that's very interesting. Anju, I don't know if you wanted to comment on her mental health a little bit more.
You mean in terms of?
I think she was under psychiatry, wasn't she, for the management of her
Yeah,
depression?
sertraline and alprazolam is by psychiatry. She is going to see, yeah, actually her next appointment. So now we've got a visiting psychiatrist that's coming in, so he is going to see her at the next visit, and maybe we can bring up some of this, what
Yeah.
Kejel then. Yeah.
Yeah, I think because like sometimes the issue that we have is that care can be very segregated. So obviously they go and see a psychiatrist, but some in the past we weren't able to see psychiatry notes, and actually that's still true for some parts in our center. So then we can't actually see what psychiatry is doing in the discussion around that. But yeah, thankfully we are able to move a little bit forward with our mental health care in our ID clinic. And she's agreed to see the psychiatrist that will be coming to our clinic as well. So yeah, that's really interesting that you mentioned about the sertraline and the alprazolam. Thank you. I think Jenny, I was very curious about what you were mentioning about the atorvastatin and the dosing. Did you want to comment a bit about that?
Well, I think the reprieve study, the pitavastatin dose that was used in reprieve, I think, is equivalent to a higher atorvastatin dose. For example, if we use rosuvastatin much more commonly in Australia. We don't have pitavastatin at all. And we would start at 10 to 20 milligrams of the rosuvastatin, which I think is 20 to 40 milligrams of the atorvastatin. But I don't know whether Grace or someone else has a better feel for the equivalent, or even Yvonne about that. But I think 20 milligrams of atorvastatin is really a very low dose. And if you are concerned about the cholesterol level, it might be worth trying to increase it a little bit. It'd be interesting to know which statin caused the myositis, and what dose was used, and whether we can actually just gradually increase it to a tolerable level.
Anju, do you remember which one it was? I can't remember.
The one that
that caused the myositis.
Yeah, it sounded like it was Simva or Prava. I think it might have been pravastatin, because it was very early on in her diagnosis. Yeah.
Right.
Switching to rosuvastatin.
Pravastatin is a very weak statin. Yeah.
Yvonne?
So just on our BHIVA rapid statin guidance, which we produce really rapidly after reprieve, it's got a table on it with all the different statins and the equivalents. So pitavastatin, the 1 to 4 milligrams would be considered moderate intensity, so the equivalent of 10 to 20 for atorvastatin. So you could, increase statin dose there. We tend to avoid simvastatin originally because of drug-drug interactions with PIs and NNRTIs, but actually we did see more myositis anyway in that context. And in the reprieve study, myositis was one of the specific side effects that was looked for, and it was equivalent in placebo versus pitavastatin. So I think statins get really bad press. The other thing to remember is that the best time to take them is nighttime. And people forget that because it gives them the best ability to work, to control lipids, but also you're more likely to sleep through those symptoms, which are most likely to occur, as we all know, in the first 6 to 8 weeks, and will gradually tailor off and don't necessarily persist. But some people get them so badly in the first 6 to 8 weeks, they just stop. So I think it would be, worth ensuring that if you are giving statin, that actually the cholesterol is significantly reduced. So thinking about increasing intensity or making sure the dosing time is correct. Because often patients are taking it in the morning and they just have it with their morning pills for some reason because they haven't been told actually nighttime is the best time. But if you want to know more about the different statin strengths, it is on the BHIVA website, so I can put the URL into the chat for you all.
Thank you. I'm actually quite curious, Yvonne, regarding bone mineral density scans. At what age are you doing them? Because I mean, you see such a wide a wide age range, right? 18 to 87. And women they become menopausal earlier and they're osteopenic.
So the national guidance currently for BHIVA would be to start at 50, or if they're menopausal, which the average age in the UK remains about 51, 52, even for women with HIV. So I think in our clinic, I've started doing them earlier from about 45. But obviously, if there's an indication, so if somebody has an atraumatic fracture, if somebody has premature or early menopause, remember that can happen with increased frequency in HIV, although it's a small percentage of women. So that's women who menopause earlier than 45 or even less than 40. And they are definitely at higher risk of any menopause-related comorbidities, such as menopause such as bone or cardiovascular risk. So I've made it my own standard to go 45. My clinic isn't big enough to have changed guidelines yet, and ultimately I would like to work with other organisations in Europe to try and, because none of us have bigger numbers or big enough numbers of women to be able to, come up with a guideline that works for every woman. So ultimately that's what I want to try and do. But in the meantime, having started collecting data at 45, I've seen that already. If I'm waiting for menopause, women are already osteoporotic, at which point they're at risk. And so stepping in with HRT at that point. But that's me. That's not based on, that's based on experience rather than any specific other guidance, because there is no specific guidance for women with HIV. There's some menopause guidance, but they're not evidence-based. There's the British Menopause Society, and then there's the HIV monitoring guidance, but none of them combine all of the issues that we need to consider with enough evidence to be able to say exactly when we need to start. But FRAX is not reliable, and we know that from Michael Yin's group. In men and women with HIV, FRAX underestimates. It's a bit like the cardiovascular risk. HIV always interferes with standard tests, and all of those assessments are no different. So I do the FRAX, but I don't generally base anything on it. I do a DEXA anyway and then look to see, and that's more data I'm collecting to see what the difference is.
Thank you. And just opening up the discussion to Jenny and Grace, I was just wondering whether you have a tendency or whether you still use a lot of TDF, or whether you have a tendency to, when women reach a certain age, you try to get them off the TDF.
I mean, I can answer what we do in our clinic. So we do use a lot of TDF. And when if we find a bone scan so we know osteoporosis in our scans is -2.5, if they go to -2, whether it's a man or a woman, we tend to take tenofovir out because we have that ability. We have Descovy, or we have 2-drug regimens. So we can do that. And we obviously have to make sure, Hep B immunity is there before we do that or consider that. So we don't automatically take it out with osteopenia. It's only if it's increasing or they're at -2 that we would do that. But that's, again, our clinic policy as opposed to kind of national guidance.
We're in an interesting situation in Australia where Gilead removed all the TDF combination pills because our government weren't happy to pay the same amount for TAF versus TDF. They wanted to pay less, so that was Gilead's response. So we only have TAF, FTC, and rilpivirine, darunavir, and bictegravir. So,
It was an automatic decision for you.
yes.
Wow, I did not know that.
Wasn't intentional, but that's what happened.
Wow.
Well, I think in Hong Kong is similar. We do have Truvada available, and so we use it barely for some situations, for example, concomitant TB drugs. Otherwise, I think most patients have been switched to TAF-based regimen. Yeah, the only exception is actually doravirine. We do not have doravirine as a single pill. So if people are on doravirine, it would be the combination that would be 3TC, TDF.
Thanks. And Kenneth, I was just wondering actually, do you see a lot of do you have a lot of clients who are women living with HIV? And what type of exercises do you recommend for them to help?
Yes, I saw quite a lot of women living with HIV in the
Mm-hmm.
past.
Mm-hmm.
So in this case, I also quite concerned about the lifestyle and also the eating habits. So because when we are talking about the diabetic care, so usually we also care about the diet, so healthy diets and also the active lifestyles. So in the past, actually we do have some difficulty to encourage the women to come out to do the exercise. So, the man is relatively active and eager to do more exercise but women, we usually they complain about I do not have time, I'm so tired, I can't do anything, something like that. So if we just ask them to just do a exercise, usually the compliance will be quite low. So based on my experience, there will be two methods. First method is you need to introduce a professional lead exercise group. For example, as a physio, I can design and lead a exercise group that is targeting the women's health. That is quite interesting. Interestingly, they if you have a title, professional lead exercise group, usually the patient will be more able to come. Actually, I did a pilot study, just like a RCT test, a supervised exercise by therapists would be more effective than just asking them to do the exercise. So the first method will be professional lead exercise group. The second method, usually I don't ask the patients to do exercise. I just ask them to go out and have some fun. For example, I lead them to do the bowling, swimming, just not an exercise, just playing. Okay, I ask a group of the peers and do some playing, leisuring, recreational activity, not talking about exercise. But in that case, they think that, oh, I'm just go out to play. So but actually it's a exercise. So in this sense, that will be easier to ask them to come out to do some physical activity. So these two tracks that I use for quite a few years, but the outcome is find out is more effective. But just asking do some exercise plan that something like that. So just for sharing.
I love that. I wish we had our psychologist on the call, then we could tap into that as well. But yeah, unfortunately, he wasn't able to join the session. Um, I think we've come to the end of the time for discussion, but I do want to thank everyone for all of their input, and I think this case has generated some very interesting points for discussion and food for thought in terms of management for this patient. So I want to thank Dr. Anjana for her presentation. And I also want to thank Prof. Yvonne as well for that very insightful talk. I'm just going to hand the session over to Farah, just from final announcements before we close the session.
All right, thank you, Prilly. Just a quick reminder, I guess, just to remember to fill out the feedback form. I will also email the attendees today to remind you all regarding the feedback form, as well as for the Malaysian clinicians not to forget to fill up the CPD Google form that I've also put in the chat box. But don't worry, I'll also email the attendees today regarding the CPD and also the feedback form. I think that should be all. Just to remind that we also have another 2 more sessions moving forward in July and also August. So I'll also be emailing you guys again regarding the sessions. Yep, I think that's all from me, really. Thank you
Thanks,
everyone for attending
Farah.
today.
Yes, thanks everyone for joining today's session. Do join us for our upcoming ones. We only have 2 left after starting in August last year. So thank you everyone for this session. Have
Thank
a
you for
great
having
day.
me.
Thank
Lovely
you.
to meet you all. Bye.
Nice meeting you.
Thank
Bye.
you, everyone. Bye-bye.
Bye.